So hello everybody, and thank you again for joining us this evening. Um, Today it's also going to be rebroadcasting a previous session that had re-recorded. So this is a pre-recorded session with Dan Lee. Going to talk about the diagnosis, update on the diagnosis and management of a superior canal abscess. He's really talking about third window syndromes, and I think what I like about this session is the fact that he has quite a few cases that could be very, very confusing in the presentations, and there's something that we really need to be aware of as we consider those patients and any surgical management of those patients. So I hope you enjoy it, and here we go. How are you, Dan?
I'm doing well, Dr. Terabishi. So,
great.
Yeah.
So here on my side, I have Arturo Poletti. He's a colleague, works with the American Hospital, and
it's nice to meet you.
Yes, likewise. Nice to virtually meet you as well.
Very well-known Italian basic skull surgeon. He's been here with us for a while.
Fantastic.
Very happy to hear you.
So then everybody is looking forward to your presentation. Thank you again for joining us. How is it? It's now 10 o'clock in Boston, right?
It is now 9 a.m. in Boston, and I
9. It's not 10? I thought it's 10.
It says 9 a.m. here on my watch.
You must be right. You would know better than me. All right, then.
Well, great. Well, hello and greetings all from rainy, stormy Boston, Massachusetts. My name is Daniel Lee, and I'm an otologist, neuro-otologist at the Massachusetts Eye and Ear Infirmary and Mass General Hospital. Thrilled to be here. I wanted to thank Dr. Terabishi for the invitation to speak during this fantastic virtual lecture series for otolaryngologists hosted by the Terabishi-Stamberger Ear and Sinus Institute. Really a phenomenal effort that you put on, Moaz. So congratulations.
Thank you. Thank you very much.
And I hope that residents in the U.S. are also maybe logged on, perhaps somebody from Iowa City, so that we can continue to support his didactic exposure during this pandemic. How is your son doing, Moaz?
Doing great. Thank you very much. Yeah.
I have no doubt. So I look forward.
Actually, the idea came from him. You know, he was telling you about that you guys have a residents online meeting and that it's really went viral. So I thought this is great, timing to do such online activities.
No question. Looking at my background, which is virtual, I'm actually sitting in my home, of course. But behind me is the Mass Eye and Ear Infirmary. And then also the Mass General Hospital. And so they are connected physically, and we represent the eye and ear specialty in hospital in affiliation with the large general hospital, the Mass General. And so this is the backdrop, and this is where I normally work. As a brief update here in our practice, I'm in the office every 2 weeks to see urgent cases. The most common diagnosis for which I come in to see patients is sudden sensorineural hearing loss. And so I basically come in to do injections. We have 10 or 11 now otologists who seem to be growing every year. I can never keep track. And so one otologist is covering the office every day during the work week. And so most of us are seeing patients, maybe 2 or 3 at a time, oftentimes for sudden hearing loss or for other urgent indications. Aside from that, all semi-elective and elective clinical interactions have been completely put on hold. My last surgical procedure here in Boston was on March 13th. I did a complicated revision canal wall down procedure, and that was the last time I've been in the operating room. So
the number of, I know you had some concerns at one time, the number of sudden hearing loss that you're seeing, is it more or less or the same as your usual level, would you say? Can you hear me, Dan? I think you're frozen. Yeah. Somehow, Dan Lee got frozen on us. Can you hear me? Oh. He went off. Okay, so let's see.
I think we're back. Can you hear me? Is the audio feed okay?
Yeah, absolutely. Thank you very much.
Oh yeah, sure, great. I don't know where we lost each other in the conversation. I think you were mentioning something about your practice.
No, I mentioned that the number of patients presenting to your clinic was sudden sensory hearing loss. Is that the sort of, have you seen an increase? Because I know that at one time you had a concern about the relationship.
Yes, I think several people have brought up this as a possible concern, but I think it's probably no higher than what it normally is in terms of its natural incidence. And so I think we're seeing what we typically see week to week. And we have a dedicated ENT emergency room at Mass SINUS, so we get a lot of patients with sudden hearing changes anyways. And so we have a fairly captive patient population in the Boston area and regionally as well who come in because we offer that 24/7 access to getting a hearing test and evaluation, at least pre-pandemic. A number of patients with hearing fluctuation we'll ask them to use a smartphone or tablet-based application to do a remote hearing test on their own. And then that is then sent to us for review. And then if it's deemed that they have a concern of a real sudden hearing loss, we'll go ahead and have an emergency in-person audiogram performed. So that's sort of how we're triaging some of those cases. It's obviously a patient-by-patient specific decisions. So there are lots of variables there, but again, trying to be careful about minimizing, the interaction of patients in the hospital if we can for these non-emergent but urgent cases.
So I think we're ready for your lecture, Dan. And
okay, so good. And so what's the COVID situation there in the Emirates, in Dubai? Have you returned to semi-elective procedures, or are you still basically on hold for now?
No, we're still on hold. We haven't, the same situation. We haven't been doing much surgery. Mm-hmm. And even the clinic, like today, I saw 2 patients, I think.
Yes.
It's very, very, very different from my usual situation.
Yeah, it's difficult to go, in my case, 78 to 80 patients to basically 0. It's we have a lot of patients who have real problems and are very symptomatic, but they're at home waiting for clinic appointments probably in the next 2 to 3 months minimum. Yeah. Well, thrilled to be here to talk about superior canal dehiscence syndrome. And let me just see, is my screen shared appropriately?
Absolutely.
Great. I've also elected to use simultaneous captioning, which is a feature on PowerPoint. It is not perfect, and it may miss a number of medical terms, and I apologize for that. But I can always turn it off during the talk if you feel like it's distracting. But because I believe this might be a global audience, I thought it might be helpful to use captioning. So today we'll be talking about superior canal dehiscence syndrome. These are my financial disclosures, none of which have any direct relationship to the topic of superior canal dehiscence. Briefly, as an overview, I will talk about the clinical presentation of canal dehiscence, or SCD, review the CT scan classification of SCD that we put forth in a paper from our institution, and underscore the importance of not just identifying a dehiscence, but actually trying to describe its location and its size, just because we believe that these features of a superior canal dehiscence case are very important for guiding treatment options. Third, we'll then briefly talk about surgical management options and then talk about outcomes following surgical management. And then the second half of my presentation, go over some illustrative SCD cases to help reinforce who is actually candidate for surgery and who should be observed. So superior canal dehiscence syndrome was described in 1998 by Lloyd Minor when he was at Johns Hopkins. The condition is essentially a bony defect anywhere along the superior semicircular canal. And this bony defect can be associated with auditory and or vestibular signs or symptoms. Dr. Minor was able to correlate a very specialized group of patients in his practice back in the 1990s who had unusual triggers to their symptoms, who on examination were found to have eye movements that were driven in the plane of the superior canal, whether it was nystagmus to loud sounds, Tullio phenomenon, or eye movements to Valsalva maneuver against a closed glottis or against a pinched nostril, were ways that he was able to link his physical exam findings on his patients with trying to identify a problem of the superior canal, because these patients had torsional vertical eye movements or nystagmus in the plane of the superior canal, driven by very specific triggers. He then collaborated with a radiology colleague in New York because at the time, Johns Hopkins did not have the ability to resolve details about the bony anatomy of the superior canal. And in doing so, he was able to then identify bony defects on imaging in his patients with very specific findings on physical exam. So hence, SCD syndrome was identified and described, and we know this to be a very important part of our practice in terms of those patients with very specialized findings clinically associated with a radiologic finding of a superior canal defect. I was very fortunate to have been Dr. Minor's medical student when he first discovered this condition, and to really begin to meet some of these very special patients from all over the globe who came with signs and symptoms of superior canal dehiscence. The incidence is not fully understood, but prevalent studies looking first at temporal bones ranging anywhere from 0.5 to 2%. In more clinically focused studies looking at CT scan surveillance of their otology practice, anywhere from 3 to 9% of patients may have a bony defect. Of course, we don't know those patients with a bony defect who actually has symptomatic canal dehiscence. We define, or rather I defined SCD syndrome as a patient with a bony defect as seen on CT scan with vestibular and or auditory symptoms, and hopefully at least one clinical test that supports a possible third window. And we'll get to the concept of third window here in a few minutes. Patients can present with vertigo or dizziness or oscillopsia. This can be triggered by sound, otherwise known as a Tullio's phenomenon, or triggered by pressure, or Hennebert's sign, and that can be pressure by way of Valsalva against pinched nostril, or Valsalva against a closed glottis, meaning straining or bearing or trying to lift something heavy. Very important, not all SCD patients are dizzy. Other common symptoms are generally auditory, and they include things like hearing one's eyeballs move, a very unusual complaint, but a very specific one to this condition. A number of patients have come to centers that take care of SCD patients after putting in their Google search engine, "I can hear my eyeballs moving." It's a very unusual thing to search for, but when you put that in, you actually find canal dehiscence on the first page. But if you put other common symptoms like autophony or ear fullness, hearing loss, or tinnitus or pulsatile tinnitus, you're not necessarily going to find SCD as your first hit. And so those patients who may have had symptoms for many months or many, many years, when they eventually hit on the right combination of search terms, can sometimes diagnose themselves and come in oftentimes with pages of Google searches saying, I think I've discovered my own condition. I think I have this problem. And so just to underscore that patients with classic SCD syndrome can have patients that are auditory, vestibular, or both. And I will tell you that back in the early days, the surgical candidates were those that had fairly debilitating vestibular symptoms or complex dizziness. And the concerns were, I think, pretty obvious. We didn't want to offer surgery on a patient who had primarily ear symptoms or hearing symptoms because of the risk of hearing loss that accompanies any sort of inner ear procedure. And it's a major operation. It is invasive. Anecdotally, I will share with you that, and we have not yet formally analyzed these data, but we will soon, that patients who have primarily auditory symptoms, like intractable autophony and fullness and pulsatile tinnitus, which can be 24/7 and can drive some patients absolutely mad, are probably the most important and increasing cohort in our practice to end up getting surgery. And I think these patients who have primarily auditory symptoms do better on average after surgery in terms of a shorter recovery compared to those patients with SCD symptoms that are primarily vestibular. Those patients generally take a little bit longer to recover on average. So how does canal dehiscence, superior canal dehiscence, actually drive the development of auditory and or vestibular symptoms? So in normal mechanoacoustic dynamics, one has two mobile windows. And this diagram helps to illustrate this concept. We have an oval window, which receives mechanical energy, which is sound. And that's being transmitted through the ear canal tympanic membrane, malleus, incus, and stapes, which sits in the oval window. The oval window vibrates and sends a mechanical wave, which creates a traveling wave through the fluids of the inner ear. The hearing mechanism is a push-pull system, and so we have a round window to help to release the pressure on the other end. So sound and sound pressure enter, and some of that fluid pressure is displaced outward at the level of a mobile round window. So in normal mechanoacoustic dynamics, one has two mobile windows, an oval and round window. We believe, and many people believe, that superior canal dehiscence causes a third window phenomenon of the inner ear. With a third window, you have decreased inner ear pressure because of shunting towards an area of lowered impedance. This happens to be the superior canal defect. You have shunting of this acoustic flow of energy here away from the cochlea. You are shunting more acoustic energy towards and across the ampulla of the superior canal. And that can generate the tulial phenomenon that is seen in some patients. Patients who get dizzy and have nystagmus in the presence of loud sounds presented to the affected ear. Because we have shunting of fluid energy away from the cochlear partition and towards the area of the superior canal or the area of lowered impedance, we have hearing loss, which can be subjective and can be measured as a conductive hearing loss on an audiogram, or an inner ear etiology for conductive hearing loss, or an air bone gap. So that is the basic concept behind a third window in the case of superior canal dehiscence. I just wanted to present a couple of examples of third window conditions that maybe some of you have not even thought about in your own practices. So this is a 9-year-old male child with bilateral hearing loss. He initially passes newborn hearing screening in Germany, now living in the States. No history of head trauma, ear infections, was wearing a hearing aid on the left ear, which was his better hearing ear, doing well in school and speaking bilingually in English and German at home. no family history of hearing loss. On exam, otherwise healthy, appearing, wore a left-sided hearing aid, normal physical examination, except that his tuning forks did lateralize to his only hearing ear, the left ear. And this is his audiogram. His left ear shows a conductive hearing loss. So we see an air bone gap in the low to mid frequencies on the left side, and anacusis on the right. So conductive hearing loss on the left, on the right side, anacusis. What else do we want to know about his hearing testing? What other tests would you want to ask for from your audiologist? 9-year-old. Or are we happy? The ear exam is normal. Do we talk to the family about offering the child a tympanostomy tube, a laryngotomy? How about tympanometry?
Then we've silenced the all the participants because we wanted this. A lot of time you get a lot of noise, so that's why you might not be hearing any answers from anybody.
Oh no, that's okay. It's okay. I know there's a question answer section for Zoom, right? Where they can actually leave text responses. Is that true?
Yeah, the chat at the end of the session, you'll have you look at the chat, and they will have
Okay.
a lot of questions usually.
Sounds good. Thank you, Moaz. So tympanometry, you want to ask for that, right? Type A in both ears in this case. What about acoustic reflexes? Maybe something we don't always order in a child especially. In this case, in a normal exam, normal temps, reasonable thing to ask for, no question about it. And in this case, they were present on the left side with an air bone gap. So based upon these findings, 9-year-old, air bone gap, normal temp, normal reflexes, we're thinking perhaps a third window, perhaps an inner ear phenomenon, nothing in the middle ear. So what would be the differential diagnosis in this child's case? Superior canal dehiscence? Maybe, although generally I've seen that condition in older children, not as many in young, although my youngest was 7 years old with bilateral SCD and hyperacusis, but unusual case. Well, this was his imaging findings. So no surprise there, right? The most common third window phenomenon seen in children is large vestibular aqueduct. And folks, don't forget that children can also have a third window from this condition presenting as an air bone gap exclusively. Just because you have a classic large vestibular aqueduct on this right axial CT scan or left axial CT scan bony windows doesn't mean you have to be deaf or have a sensory neural hearing loss. And in his case, as you can see, he has anacusis on one side because of this condition, but his aqueduct is causing an air bone gap exclusively on that side. And I've met a number of children in my practice who were diagnosed with eustachian tube dysfunction or presumed otitis media. A tube was placed for the air bone gap, which was due entirely to another process. Why? Temps were normal and they still put a tube in, or reflexes were not done. So please don't forget about the large vestibular aqueduct phenomenon, especially in your kids with an air bone gap and normal tympanometry. You don't want to miss this diagnosis in a child, to be sure. Another patient, 42-year-old woman with left-sided hearing loss. And the threshold audiogram here shows a mixed hearing loss. So you have an air bone gap on the left with a slight mixed component, so mild mixed hearing loss on the left side. The right side had normal thresholds, and so I didn't show that testing on this hearing test. Normal exam, normal tympanometry, and finally, normal reflexes. So differential diagnosis would include superior canal dehiscence, certainly. She, as her only clinical complaint, noted hearing loss on the left. And of course, I did remind you that SCD patients can present with only auditory symptoms. What else? What else could cause a third window in a 42-year-old woman? Same thing. Adults can present with normal to near normal hearing and still have a large vestibular aqueduct. And I've seen a number of patients in my practice with single-sided hearing loss. An MRI scan was done and ruled out a vestibular schwannoma, but they missed on the T2-weighted sequence the large vestibular aqueduct. So don't forget that adults can present with fluctuating hearing losses and have a large aqueduct, and that is easily seen on an MRI scan. You don't need to get a CAT scan to further work their ear symptoms or the hearing loss up. An MRI scan with reasonable T2-weighted axial cuts can easily pick out a large aqueduct. So don't forget about the large vestibular aqueduct as a possible etiology for a patient with an unexplained air-bone gap, and especially in kids, you do not want to miss that diagnosis. And so again, it's working as a shunt, much like superior canal dehiscence. And so in this model, we see sound-driven energy entering the fluids of the inner ear, and rather than having shunting away from the cochlea to the superior canal, you have shunting away from the cochlear partition towards the area of lowered inner ear impedance, in this case, the large vestibular aqueduct. Let's see here, excuse me just a second. All right, okay, so as a take-home message again, children and adults with large vestibular aqueduct can present with conductive hearing loss, mixed hearing loss, or sensorineural hearing loss. Going back to SCD, what causes SCD? Well, we don't really know entirely. The number of theories that have been put forth. On the congenital side, on the congenital column, the prevalence of SCD appears to be high in children under the age of 2, but does decrease over the first decade of life. And this is just an observation that reflects general skull base development. The bone of the skull base is generally adult thickness by the age of 4 or 5 years of age. Second, there does not appear to be evidence of bony remodeling in a temporal bone study looking at 5 cases of dehiscence of the canal and 14 cases of near dehiscence or thin bone over the superior canal. So the lack of evidence of bony remodeling suggests a possible congenital etiology to SCD. There are cases of familial SCDS, but they are rare. And there appears to be a higher incidence of SCD found in patients with a documented Usher syndrome 1D. On the acquired column, there has been cases of bony remodeling seen at the level of the middle fossa in the setting of an adult patient with superior canal dehiscence. And that was a temporal bone study that was presented during one of our webinars from Boston about 2 years ago. There is evidence of osteoclastic activity in the temporal bone. There are only limited cases of familial SCD. Up to 25% of patients, there is onset of symptoms associated with head trauma. And also there is a possible association with elevated intracranial pressures associated with higher body mass index and OSA. And that is an interesting observation, but I'll tell you that in our practice, in a paper that we published, the patients who underwent surgery for canal dehiscence, for SCD, did not have a high BMI. So patients who underwent surgery for SCD syndrome were not obese. So I think the jury is still out. I think we need to have more research, more studies, and truly understanding this. And I think what will be useful is to begin a study where we examine and do whole exome sequencing to really be able to pinpoint what some of the genetic changes might be associated with in our SCD patients. And we do have a number of families in our practice in Boston in whom we could begin to study and try to answer these questions. We did publish a paper, a small series from Boston, looking at a group of family members with superior canal dehiscence syndrome. These are 3 separate families, first-degree relatives, 2 brothers, a mother-daughter combination for the second and third families. So a really interesting glimpse into a group of patients who have first-degree relatives with the same condition documented by CT scan, as well as audiogram and VEMP findings. So evaluation, as we talked about in some of the earlier cases here, clearly threshold audiogram is going to be key, looking for a low frequency airbone gap or a mixed hearing loss in some cases, and sometimes normal hearing. There are some patients who have a hole in their head, but actually have no clear signs or symptoms or clinical testing suggesting active SCD. So you could have a patient come in with a positive CT scan and normal hearing. Again, just because you see SCD on a CT scan doesn't mean it is the cause of the patient's problem, no matter what your referring physician tells you, or your patient especially. Supranormal bone conduction is a really great way to screen patients in your practice in whom you suspect a third window phenomenon. So, and I've been often asked this question when I've given talks on this topic. You know, we can't screen everybody with CAT scans, and we also don't have great VEMP testing yet that's been validated in our own center. What can our audiologists do to help screen for these kinds of patients? Ask them to look at supranormal bone conduction levels. Oftentimes, audiologists will not do this if the air conduction thresholds look normal. Ask them to use supranormal bone conduction in your symptomatic patients, and you may pick up a few patients and actually come to a diagnosis that might be a third window in those cases. Again, a great way to screen your practice for third window patients. Tympanometry, usually normal in SCD, but it can be hypermobile in some cases. And I believe that's the case because in these patients with very large bony defects, you have such a significant change in inner ear impedance that the stapes is hypermobile, and that reflects a change in tympanometry. And I could be wrong, but we certainly need to model this in the laboratory to really understand if that's the case. But I have seen a few patients with large bony defects that have hypermobility on tympanometry. Acoustic reflexes, right? This is a sound-driven measurement of the activity of the stapedius muscle, which then contracts, pulls on the stapes, stiffens the ossicular chain, increases middle ear impedance, and that results in a change in the pressure that is measured in the ear canal, right? That is the acoustic reflex. So it's usually normal and present with SCD because the SCD phenomenon can drive a inner ear conductive hearing loss, which is not associated with an ossicular chain problem. But it can also be absent. So SCD can still be present, but be masked by middle ear pathology. So if you have ossicular fixation, if you have stapes fixation, that might mask an underlying canal dehiscence. Yes, we know all about all those cases where the audiogram showed conductive hearing loss. The surgeon took the individual to the operating room and did stapes surgery. It didn't work. It turns out the CT scan shows canal dehiscence. And those patients probably didn't have otosclerosis, but there are patients who do have both. And so for that reason, at our institution, we now recommend using a CT scan to evaluate your patients with suspected otosclerosis if you're considering surgery. We have had several cases in Boston where the patient had clear-cut findings on hearing testing of ossicular fixation and normal exam. They went and had uneventful surgery, and they woke up with new SCD symptoms. Stapes surgery can unmask new SCD symptoms if a patient has both conditions, and you're not going to know that unless you have that preoperative CT scan. We use a cone beam or flat panel CT system in Boston. It's less expensive. There's less radiation exposure. The patient sits in a chair. As you know, the thing spins around your head. They love it. The picture quality is fantastic. And we use this to be able to image the middle ear in these cases. So let's just say you have a patient you did stapes surgery on. The patient now has SCD symptoms that are new. They're absolutely miserable. They want the repair of SCD. What do you do? In these cases, we've actually discouraged for the surgery because they've already had one inner ear procedure, the stapedectomy, and now you're proposing doing another inner ear procedure to repair the superior canal. There is a greater risk of a sensory neural hearing loss. Unfortunately, these patients are stuck. And so they might consider surgery, but I think one has to be extremely conservative for the risk of sensory neural hearing loss. And so again, for this reason, because even if you do unmask a new SCD diagnosis, you then can't always repair it. So be very careful. I'd recommend imaging anybody in whom you suspect otosclerosis just to make sure you're not missing out on something else, whether it's SCD or an associated malleus fixation. Just a great way to interrogate the anatomy to make sure you're fully prepared for anything in the operating room. And of course, if you do find SCD in your patients with clear-cut testing confirming fixation, we would then recommend what? Hearing aids. We would not touch that patient surgically at all. Let's talk about vestibular evoked myogenic potentials or VEMP testing. So C-VEMPs or cervical VEMPs have really become the mainstay electrophysiological measure to be able to understand if the inner ear has been influenced by the presence of SCD. Most centers use cervical VEMPs or cervical vestibular evoked myogenic potentials. These are sound-triggered inhibitory potentials of the sternocleidomastoid muscle. It's a test of saccular function, meaning inferior vestibular nerve function. And in SCD syndrome, patients with a positive C-VEMP finding have what? They have low threshold C-VEMPs. Low threshold C-VEMPs. Yes, their amplitudes also can look larger when you look at the tracings, but the more reliable measure on C-VEMP measurements should be thresholds. So if your center is presenting amplitude data on C-VEMPs, they really should be presenting threshold data for your C-VEMPs. What about ocular VEMPs? Ocular vestibular evoked myogenic potentials. These are air or bone conduction sound triggered excitatory potentials of the inferior oblique muscles. So unlike the cervical VEMP, which is inhibitory, the O-VEMP is excitatory potentials, in this case of one of the extraocular muscles, the inferior oblique. This is an assay of primarily utricular function, otherwise known as, a function through the superior vestibular nerve. And in SCD syndrome patients, O-VEMPs generally are large amplitude. So cervical VEMP, low threshold. SCD syndrome for O-VEMPs, large amplitude. But of course, not all symptomatic SCD patients have a positive finding of a VEMP. But if you have a positive finding on VEMP testing, it's a very specific outcome measure on your testing that can help you to come to the correct diagnosis for your patient. So in what situations do VEMP testing results not help in the diagnosis of SCD? Well, these are all conditions that might influence how the test is performed. So TM perforation, not helpful then, right? Because it's going to totally throw off your measurement. A TM retraction, same thing. Or a patient with significant scarring or prior middle ear surgery is obviously going to throw off the C-VEMP testing. Otitis media for the same reasons. You're going to get very high threshold VEMPs. Saccular fixation, again, you can do a C-VEMP in a patient with suspected otosclerosis, but it's only going to give you a very high threshold because, again, with the conductive hearing loss, you're really minimizing how much sound energy is being delivered to the inner ear to be able to get a response. So it's not going to be helpful in cases where there's middle ear pathology. And what about a patient with severe to profound hearing loss? Can you drive a VEMP response? The answer is absolutely. Unless the patient has vestibular hypofunction as a consequence of their hearing loss, recall that the VEMP pathway does go through the inferior vestibular nerve in the case of the cervical VEMP, and is really a mechanical mechanism by which the system is being stimulated that does not require hearing. So although the VEMP test uses sound presented to the ear, even in a deaf ear, the sound in this case is being used to drive mechanical stimulation of the sacculus, which then stimulates the inferior vestibular nerve, and then the rest of the pathway resulting in inhibitory potentials recorded on the neck muscles. So yes, a CVEMP can be seen in a deaf patient. Let's talk about radiology. So standard radiological coronal views are not sufficient to fully appreciate the bony defects seen in a number of patients with superior canal dehiscence syndrome. So in our SCD radiology protocol, CT scan protocol in Boston, and this is a protocol used by many centers around the globe, we perform Petrosal planes parallel to the superior canal. So this is a CT scan bony windows in the plane of Petrosal, parallel to the superior canal, and we see a lack of bone over the superior canal and the arcuate eminence with an associated tegmen tympani defect and dural contact to the ossicular head. So two reasons why this patient has conductive hearing loss, as well as radiologic views reformatted to the plane of Stenvers, which is perpendicular to the superior canal. So again, we're looking at the superior canal, but now in the perpendicular plane. And we can see the lack of bone over the arcuate eminence associated with a large tegmen mastoidium defect. So Petrosal plane and Stenvers plane are two important additional reformats that you should ask for in your patients in whom you suspect canal dehiscence. The coronal plane is just not sufficient. But you want to be able to see all four planes in high resolution: axial, coronal, Petrosal, and Stenvers. Because not all defects look like these. This is the classic defect, but some are on the side, some are medial, some are lateral. To really appreciate the location and extent of defect, you need to see all four planes. Why MRI scan in SCD patients? Because you want to rule out central pathology. Vestibular schwannoma, intralabyrinthine schwannoma, encephalocele. Some of these conditions can also add to the patient's symptoms. Please get an MRI scan if you're evaluating a patient, especially with vestibular symptoms. Even if you have other clear-cut findings suggesting SCD, rule out other central pathology. There have been reports of meningiomas causing erosion into the superior canal that were not seen on CT scan. I had a patient in my practice who had an outside MRI scan whose quality was not great enough to see the cochlea. He had an okay result after SCD surgery. I repeated an MRI scan, as I always do after SCD surgery. He had an undiagnosed intralabyrinthine schwannoma. And had I known that before SCD surgery, I probably would have not offered surgery, knowing that the fate of that ear will likely be continued inner ear hearing loss as well as vestibular damage. Our CT classification published 9 years ago and more recently 6 years ago. We looked at 202 patients with SCD, of which the majority were adult patients, 198 adult, 4 children. We looked at a number of different features on these CT scans, including size and location of defect, the status of the tegmen, the status of any bone overlying the facial nerve at the level of the geniculate ganglion, as well as proximity to the superior petrosal sinus. Importantly, 50% of these cases had a dehiscent geniculate ganglion. And so if you are considering surgery, which primarily involves skull-base dissection in the area of the facial nerve to get to the superior canal, please be wary. Half of these cases will have a dehiscent facial nerve. And yes, you might see it on the CT scan, but even if the scans aren't great, just assume that it's probably dehiscent. 38% had a low-lying tegmen. and 12% had a tegmen tympani defect. And so we were a little bit surprised to see that there was a fairly low prevalence of skull-base defects in general with SCD. And so it does suggest to us a unique and perhaps different pathway, different pathophysiology than those classic cases of spontaneous CSF leaks associated in some cases with high BMI and OSA. So in the normal superior canal, we have bone covering the entire superior semicircular canal. So this is the ampullated end, arcuate eminence, the descending limb towards the common crus. And this is an example CT scan in the petrosal plane showing intact bone over the superior semicircular canal. And there is the opening of the what? The subarcuate artery. Now, the arcuate eminence defect is the most common type of superior canal dehiscence. And this is seen in about 95% of patients with SCD. In this case, you have lack of bone over the top of the superior canal. And during surgery, oftentimes we will observe that dura mater and even brain has begun to enter these larger defects. In some cases, patients who present to the office with large canal dehiscences are surprisingly minimally symptomatic. And I believe that the reason for that is, in these cases, the dura mater and the brain have slightly herniated into the defect, creating an auto-plugging situation. And so this is a CT scan which provides a nice example of a classic arcuate eminence defect, as shown here, and this is 95% of cases. The medial defects are less common, and these are associated with the superior petrosal sinus, that venous sinus that runs along the petrous ridge of the temporal bone. And so the arcuate eminence in these cases are totally intact. They do not have low-lying tegments, but they have a defect along the medial or descending limb of the superior canal. And this is shown here in this illustrative CT scan. So about 4% of patients have a medial defect. We believe that these are not safely approached using a middle fossa craniotomy because the defect is very medial. Looking around the corner and then deep is very difficult, especially with a microscope. And then when you get there, you've got to dig out a vascular structure, which could cause bleeding deep in the skull base. And so we would favor a transmastoid approach in these particular cases of superior canal dehiscence. And then unusually, we had one patient of the 392 ears that we examined that had both defects, both an arcuate eminence defect as well as a superior petrosal sinus defect. And I tried to find this one CT scan image that captured both. And so you can generally see that there's a defect here, which you would see in a better image if I were to scan through it, as well as the petrosal sinus defect more clearly shown here. And so this patient underwent a transmastoid approach where we isolated both bony defects by plugging this area here and this area here. So we treated this as one large defect. And he's about 4 or 5 years now post-op and doing well with good control of his symptoms. So management options, observation. No question, observation should be the management option for virtually all of these patients. Most patients who present, at least to us, have mild symptoms. And so this represents about 2/3 of patients in whom we diagnose superior canal dehiscence in our practice. What about surgery for those with severe auditory and or vestibular complaints? Middle fossa craniotomy, transmastoid repair, and third and somewhat more controversial would be round window plugging. The plugging or occlusion approach is the most common approach used worldwide. It's oftentimes done through a middle fossa craniotomy approach, and I favor that approach because I feel like I can do it safely and quickly through a small incision and small bony opening. I can directly see the dehiscence. I can quantify it visually. I can measure it. I don't have to use a drill to open up the labyrinth in any other way, so I'm not introducing more mechanical energy to the inner ear. I like to use bone wax, which I then will occlude the defect to be able to seal it off. And our temporal bone studies led by Dr. Heidi Nakajima in Boston suggest that to create a successful outcome, a durable outcome, you need to create a watertight seal. And that is why the attempted resurfacing approaches that Dr. Meyer tried 20 years ago were not great because of the high recurrence rate. So again, this is the occlusion or plugging approach, which is the most common approach used to be able to create a durable seal and a long-term outcome, which is hopefully positive. It has its risks, of course. This is a brief video that highlights an example of a middle fossa approach.
Repair of a superior.
I just muted the volume. It has its own audio stream. So CT scan shows a dehiscence of the arcuate eminence along a very downsloping tegmen. And so with a microscopic approach, this would be impossible to visualize. This is an example of the middle fossa incision, which is actually a very small incision over the ear with minimal hair shave. We're dissecting with a binocular microscope. This is the skull base. This is the brain behind the pledget. The ear is down here. This is the left ear. With the microscope, we could not see the defect at all. With a 0-degree endoscope, we can now visualize the arcuate eminence defect. We see the dura mater of the temporal lobe of the brain, the rest of the skull base. I'm dissecting to try to get a readout on the entire extent of the dehiscence towards the descending limb. This would be the ampullated side. I'm using an angled endoscope to see the ampulated and the non-ampulated ends of the superior canal. You can even see the gray area of the membranous labyrinth, a really fantastic readout visually of the defect. I favor the use of bone wax minimally and very slowly to be able to plug the canal. Because bone wax and other materials that you might use, fascia, cartilage, etc., can migrate, you have to be complete but conservative with your repair because you don't want to over-occlude the dehiscence, or your repair materials may end up migrating into the ampulla or into the vestibule in very, very severe cases. So be extremely cautious with these maneuvers to ensure that you've occluded both the ampulated and non-ampulated ends of the superior canal. The indirect approach is transmastoid. You do a mastodectomy, canal up. You then blue line both limbs of the superior canal. I like to make then tiny openings on the ascending and descending limbs of the superior canal to isolate the defect and use bone wax and bone pate to plug each of these openings to isolate the defect. And this is my favorite approach, as you heard, when you have a medial defect from the superior petrosal sinus. This is a right ear transmastoid case. This is your tegmen, your root of zygoma, your ear canal. So this is a right ear, superior, anterior, inferior. This is the horizontal semicircular canal. And here we're drilling along the superior canal. And so we've already repaired and occluded the ampulated end of the superior canal. And here we're opening and then now occluding the non-ampulated end of the superior canal. So ampulated end, non-ampulated end, and the defect is somewhere right about here. This is your horizontal semicircular canal. What about resurfacing? Many of my colleagues like to talk to their patients about resurfacing. This is what they claim they're doing in order to preserve the lumen of the canal and preserve function. And no question, this is the ultimate desired outcome that we all wish to strive for. The reality is it's very difficult to achieve classic resurfacing and create a durable, watertight seal. We know this because I see a number of patients who still have symptoms after resurfacing, as shown on their operative reports, with a cartilage cap or a bone chip. We do the MRI scan, which I always do before considering surgery. We look at the fluid signal, and guess what, folks? These patients are partially plugged, but not completely plugged. That is why they are still leaking lymphatic fluid, lymphs from the inner ear, and experiencing third window symptoms. In order to, I believe, create a long-term outcome, you need to plug the canal. And I believe that successful resurfacing, and resurfacing is successful. Why? Because it's a gentle form of plugging. If you were to do an MRI scan in all those successfully resurfaced cases that are published out there, my prediction is many of them would be gently plugged. You would see a lack of fluid signal in the MRI scan. And we published a paper recently showing the utility of the MRI scan in being able to interrogate the status of the superior canal after primary surgery. Was the canal plugged? If it is plugged, was it adequately plugged in relationship to the extent of the bony CT scan findings? What about round window plugging or reinforcement? So a very attractive alternative to doing a repair via transmastoid or middle fossa craniotomy. Unfortunately, the outcomes are variable. And so let's just take you through the actual procedure itself. This is an endoscopic round window occlusion for left ear canal dehiscence. This can be done microscopically, of course. We're elevating the tympanomeatal flap. We've identified the fibrous annulus. This is the left ear, anterior, superior, inferior, posterior. We're completing the tympanotomy, and we're exposing the ossicular chain. And what we're going to see is we're going to palpate the ossicles and try to observe movement at the round window. And you will see that all ossicles are entirely mobile. So pay attention here. We tease off the pseudomembrane to get a better direct readout visually of the round window membrane proper. And as I palpate those ossicles, guess what? Zero movement at the round window membrane at all. This is the first demonstration of a third window in action live in a surgical case. This was a patient who came to see me after her first successful surgery because she has bilateral SCD and she didn't want another craniotomy, and I get that. She had some vestibular dysfunction after her first surgery, and so she was concerned about the second ear. So I attempted a round window plugging for her other ear. It mitigated her symptoms for about 3 months. She was very happy, but then the symptoms returned. She came back to the office, and about 2 years after her original first surgery on the other ear, she underwent craniotomy surgery for the second ear and otherwise did well. So outcomes following round window surgery for SCD. Some reports, no question, suggest reasonable outcomes, and I'd love to hear more from my colleagues who do more of this work. But I believe there's no consistent long-term SCD symptom improvement after round window occlusion or reinforcement. Some patients get worse, and some patients actually have lost hearing after round window surgery. So it is not as benign of a surgery as one might think. So I'll be very cautious before offering this. I would rather offer conservative management in terms of observation than round window surgery. And so I've not done any more round window procedures in my practice. For failed surgeries following round window reinforcement, we have shown in a recent study published in 2019 that in fact you can plug these cases after failed round window surgery and not increase the risk of hearing or vestibular dysfunction. Dr. Terabishi, do I have a few minutes to go over a case or two?
I think we should start answering. There's quite a few questions for you on the chat line.
Okay, well, let's go ahead and start by answering some questions. I will...
Can you check the chat?
Yep, I'm looking here. Let's see here. Okay.
So I think we're gonna stop here. Thank you very much for joining us. This is the end of our work week here in Dubai. So we're gonna have start our weekend. Thank you all, and I hope to see you next week. Have a nice evening. Thank you.